everyone. My name is Lida Bighash. I am a clinical pharmacist specialist at Denver Health Medical Center, and I work specifically in the oncology clinic. Today, I'll be presenting on treatment toxicities and interventions. And obviously, this is a broad topic for oncology, and so I will narrow this down a little bit by focusing on a few select toxicities. And I'd like you to be able to recognize those common toxicities based on therapeutic class, understand the pathophysiology behind those select treatment toxicities, and also their management. First, I will talk about traditional cytotoxic chemotherapy, and then I'll move on to immunotherapy in the second half of my presentation. So for traditional cytotoxic chemotherapy, still heavily utilized in practice, all of these different drugs have a common goal of destroying rapidly dividing cells in the body. Uncontrolled cell growth is the hallmark of cancer, and these agents do share common side effect profile, although of course each are unique in their specific mechanism and specific toxicities, but they do share some common side effects such as myelosuppression. This picture depicts where in the cell replication cycle each type of drug agent works. So for example, antimetabolites like gemcitabine primarily work in the S phase or DNA replication phase, whereas taxanes up at the top mostly work in the M or mitosis phase. Specifically moving on to probably the most feared side effect of chemotherapy for patients, that is, which is nausea and vomiting. This does exist to some degree with all cytotoxic chemotherapy agents, and the image on the right depicts why this occurs. There are two pathways specifically that we think of when it comes to the pathophysiology. First, the central pathway, where the chemotherapy toxins come into contact with the chemoreceptor trigger zone located in the area postrema of the brain. Then that leads to results of neurotransmitter release, and specifically neurotransmitters like serotonin, substance P, and dopamine, which are the ones implicated in nausea and vomiting. There's also the peripheral pathway, which involves serotonin receptors in the GI tract, and those can be triggered directly by the chemotherapy toxins and lead to mucosal injury. And both of those pathways converge in the vomiting center in the medulla. And that's the processing center for all of these afferent impulses that initiate emesis. Now, the guidelines focus heavily on prevention, and that is because nausea and vomiting is certainly much easier to prevent than it is to treat. So for the guidelines, they specifically delineate recommendations depending on the emetic risk potential of the drug. So this is for IV medication specifically on the left. For high emetic risk regimens, I want to emphasize one of the recent updates that both NCCN and ASCO have given, and that is to add olanzapine upfront to all regimens that have a high emetic risk potential. And then you do have your backbone still of the NK1 receptor antagonist, which is something like aprepitant, and your 5-HT3 receptor antagonist, which is something like ondansetron. And then, of course, the steroid dexamethasone. For a moderate emetic risk, the recommendation didn't change for the primary recommendation, which is to utilize the ondansetron 5-HT3 receptor antagonist with the steroid. But of note, you can also modify this. There are other regimens that can be utilized instead. And one 3-drug regimen with olanzapine may be used upfront with either high emetic risk or moderate risk. Don't forget to counsel the patient on the subsequent days of therapy for anti-emesis. And this is very important because, of course, it heavily relies on them and their responsibility. So again, for IV drugs, this is what is recommended per the NCCN guidelines. For high emetic risk on days 2, 3, and 4, they are to continue the olanzapine on days 2 through 4, as well as the dexamethasone. For moderate risk, either the dexamethasone or the 5-HT3 receptor monotherapy can be continued on days 2 and 3. For low risk regimens, only as needed drugs are needed for the subsequent days of therapy. There are several emetic risk additions to the guidelines, as of course there have been many new oncology drugs lately. We do have a high risk drug that is new, the sacituzumab govitecan, that is used in the triple negative breast cancer metastatic setting specifically. A few new moderate risk drugs like trastuzumab deruxtecan, also used in breast cancer. Low risk drugs like isatuximab and tafasitamab have been added, and then a few minimal risk with combination drugs as well. I want to move now to the classic side effect of neuropathy, which is another commonly encountered effect of cytotoxic drugs. Of course, more so with certain drugs than others, but the ones that do cause neuropathy, all of them share the common effect of physical damage to the neurons by the agent. That leads to functional impairment in the neurons through oxidative stress and inflammation. The mechanism for this is depicted in this picture, specifically near the top right, you'll see the taxanes. These prevent microtubule depolymerization, which leads to the impairment of the axonal transmission. Vinca alkaloids have a similar but different mechanism. They prevent microtubule polymerization instead of depolymerization, which also leads to axonal degeneration. You'll also see depicted here mitochondrial dysfunction, which agents like platinums can cause as well. On the left here are the most common drugs that you'll see that cause neuropathy. And I am focusing here on more of the traditional cytotoxic chemotherapies, but of course there are new agents that certainly can cause neuropathy as well. But most commonly you'll see the taxanes like paclitaxel and docetaxel, the vinca alkaloids, especially vincristine, platinum agents, and then some of the newer drugs like bortezomib for multiple myeloma can cause quite a bit of neuropathy, as well as brentuximab vedotin for lymphoma. On the right, I wanted to present to you the grading of the neuropathy, and this is based on the CTCAE criteria, which is the common terminology criteria for adverse events. And this is specifically from the latest version 5. It's important to recognize the different stages of neuropathy because that will dictate what treatment and supportive care the patient needs, and of course what counseling they need next. So grade 2 neuropathy is where the patient has moderate symptoms that limit instrumental activities of daily living. Instrumental ADLs include things like preparing meals and shopping, whereas grade 3 limits self-care ADLs, and those are things more like dressing and bathing at home. And then of course, grade 4 is where it's life-threatening and urgent intervention may be needed. For initial management of neuropathy, I do want to emphasize non-pharmacologic measures first, because this is first what I think of rather than right away wanting to add another medication to the patient's long medication list. Think about other ways first that potentially we can manage this. Chemotherapy dose reduction is a common thing to do. Of course, this will vary depending on the agent that's being utilized, but in general, I recommend a 20 to 25% dose reduction for taxanes, for example. Discontinuation of the offending agent certainly is an option. It's a very individualized choice, and of course will depend on many things, including whether the patient is receiving curative treatment or palliative treatment. Avoiding cold temperatures can help, particularly with the drug oxaliplatin, which, as you probably know, the neuropathy from that is certainly exacerbated by cold temperatures and by drinking cold products. And this lasts for 5 to 7 days after receiving the oxaliplatin, sometimes longer though. Physical activity, massaging the affected area, as well as acupuncture are all things that have been suggested to be helpful. Not a ton of solid evidence for those, but these things are harmless and there is some evidence to support their use. For pharmacologic management, sometimes this is necessary. And so I want to talk about the primary drug classes that you will see used in your patients for neuropathy. First line, we typically recommend one of the anticonvulsants, such as gabapentin or pregabalin, or an SNRI, which is a serotonin norepinephrine reuptake inhibitor. Duloxetine is the agent that is recommended specifically by ASCO, but you will see other SNRIs like venlafaxine used as well in this setting. Limitations of these drugs are that they do have to be titrated up, and sometimes over a long period of time, such as with gabapentin. And the higher up you go on the dose, the more complicated the regimen gets and the more side effects the patient may get. So that certainly can be a barrier. Tricyclic antidepressants, or TCAs, are sometimes utilized, things like amitriptyline, just less so probably because of the side effect profile. Sometimes topical agents can be used, particularly in combination with other systemic therapies. There really aren't a whole lot of good clinical studies evaluating these, but there are anecdotal reports of compounded creams or gels like baclofen, ketamine, amitriptyline compounded together that may be efficacious. Finally, systemic treatment with NSAIDs or opioids may be necessary. Of course, this is not our mainstay for treating neuropathic pain, but in combination, it may help and certainly can be considered as an option. Another question I get is for a variety of supplements and vitamins that have been proposed to potentially be effective either in prevention or in treatment of peripheral neuropathy. And one question I commonly get asked is, does vitamin B work? Well, it is a difficult question, mainly because the evidence we have is limited, also because the studies that are out there are heterogeneous and they look at different formulations of the vitamin B. Some of the studies only look at vitamin B12, some look at vitamin B6, whereas others look at the vitamin B complex. So it's hard to gather a lot of definitive data from the heterogeneity of the studies. A 2017 mini review on B group vitamins and chemotherapy-induced peripheral neuropathy, or CIPN, by Schloss and colleagues looked at a variety of trials, 7 of which were human, and 5 of these were randomized control trials. And unfortunately, there was no conclusive evidence to suggest that vitamin B should be recommended for protection or treatment. That being said, there were some studies that trended in the direction of providing some benefit for some patients. The 2020 ASCO and joint ESMO EONS EANO guidelines agree with this. They do not recommend that vitamin B be used as a neuroprotectant agent at this time. That being said, it is relatively harmless at the doses normally used. And if the patient wants to try it, I don't think that it will impact the efficacy of the chemotherapy in most circumstances, as long as it's a normal dose. So maybe can be utilized and may be effective for some patients. Now I'm moving on to the last side effect that I'm going to talk about in relation to cytotoxic chemotherapy, which is mucositis. This is huge for cancer patients. Up to 80% of bone marrow transplant patients experience mucositis, as well as up to 40% of patients receiving any anti-cancer drug. Also, everyone undergoing treatment for head and neck cancer will experience some degree of mucositis. This is a huge problem for a variety of reasons. This leads to problems with food intake, which leads to nutritional imbalances and increased infection risk as well. For the mechanism of action, it is a little easier to understand because the chemotherapy is directly attacking the submucosa and epithelium. That leads to an innate response to damage within our bodies and amplification of that response, which leads to ulceration, and finally healing at the last stage eventually. For grading of mucositis, again, important to mention, grade 2, it's moderate pain, but not yet interfering with oral intake. At grade 3, it is interfering with oral intake. So of course, a very serious presentation of mucositis at that point. There are many agents that can cause mucositis. So this list certainly is not comprehensive, but these are some of the most common cytotoxic drugs that we see mucositis with. Things like doxorubicin, 5-FU or 5-fluorouracil, and I want to emphasize that's mostly the bolus form of 5-FU, not so much the infusion of the drug. Then there's cytarabine, methotrexate, and high-dose etoposide and high-dose melphalan, which are used in the stem cell transplant setting. Prevention is also key along with management, of course. Prevention, again, there are limited studies to suggest that anything truly helps, but in general, good oral hygiene is recommended across the board. And in fact, the mask guidelines recommend that every patient receive an oral comprehensive exam prior to starting any chemotherapy drug. Now, that's not often done in practice due to logistical reasons and whatnot, but regardless, it's there, important to note. Other than good oral hygiene, baking soda rinses are commonly recommended, and many recipes are out there for what to use. Specifically, I generally recommend a 1/4 teaspoon baking soda in about 6 ounces of warm water with a little bit of salt, and having the patient swish and spit that out 4 to 6 times per day, more if necessary, since it's pretty harmless. Other things that can be recommended for prevention or treatment, there are topical mucosal protectants. Again, not a whole lot of evidence here, but there are things that exist. Agents like kaolin and pectin, which are mucosal protectants. There are some other bioadherent mucosal oral gels over the counter that can be recommended. Other things like oral cryotherapy for select treatments may be considered, and I will talk about that more in just a second. And finally, systemic analgesia sometimes is recommended, especially in the stem cell transplant setting where the patients get very severe mucositis and typically are started on a PCA. Now, an interesting question again is, does oral cryotherapy work? What that is specifically is essentially having the patient chew on ice chips while they are receiving chemotherapy that can potentially cause mucositis. And more evidence for use of this is available in the severe mucositis setting. But again, evidence is limited overall, unfortunately, but there is enough for some of the guidelines to advocate for use of oral cryotherapy, but in select circumstances. For example, the MASK ISOO systematic review does recommend oral cryotherapy in patients undergoing autologous stem cell transplant with high-dose melphalan. There are several studies that has shown some benefit for patients there. Also, in patients who are receiving bolus 5-FU, they recommend 30 minutes of oral cryotherapy. 30 versus longer, like 60 minutes, has not been shown to be any different. A meta-analysis in the International Journal of Nursing also looked at 15 randomized controlled trials with 919 cancer patients. And they did find that overall oral cryotherapy did lead to a lower level of mucositis. However, this was a very generalized conclusion and the studies were quite heterogeneous. But overall, the studies that were included were of the same patient population that I mentioned already, which are patients receiving high-dose chemotherapy for stem cell transplants and patients receiving 5-FU. And one of the studies looked at cisplatin as well. So across the board, there's not a lot of good evidence for it, but specifically in a couple of circumstances, there's more evidence to recommend. Now, finally, I'm moving on to immunotherapy for the last portion of my presentation. And immunotherapy, of course, is heavily utilized, has exploded in recent years, and you're very likely to see this used in many patients. Mechanism behind it is important to note because that is what leads to the treatment toxicities and helps you understand why they occur. So T-cell suppression or immune system suppression is one main mechanism for tumor growth. And this allows tumors to proliferate because the immune system is letting the tumor cells go by. And there is this regulatory system that takes place that is putting the brakes on our immune systems, with receptors like PD-1 or programmed death 1 and PD-L1, which is the ligand. These specifically promote T cell exhaustion, which leads to immune suppression. So some of the immunotherapy drugs directly target these receptors, such as PD-1 inhibitors, nivolumab and pembrolizumab. And blocking these receptors essentially leads to T cell activation, which leads to inhibition of tumor growth. Also, unfortunately, can lead to certain side effects. And you can imagine if you're stimulating the immune system, overstimulation can lead to problems. So one of those problems being colitis. The NCCN guidelines for management of immunotherapy-related toxicities are a very useful tool for dictating management, specifically breaking down the side effects by grade, once again. So for grade 1, a mild colitis that can occur pretty commonly, up to 30% with ipilimumab, for instance, considering holding treatment is already at grade 1. So right away, you need to take action. Supportive care with loperamide, maybe diphenoxylate atropine is recommended already, as well as infectious workup and close monitoring. For grade 2, which is defined as 4 to 6 stools above the patient's baseline per day, the recommendation is to already hold treatment at this stage of colitis and to start high-dose steroids with prednisone, 1 to 2 milligrams per kilos per day. With grade 3 to 4 colitis, inpatient care usually is recommended and a good idea since the patient is becoming so dehydrated at this point. IV methylprednisolone is specifically recommended at high doses, probably because of absorption issues related to oral steroids. If no response within a few days of therapy, the guidelines do suggest considering adding infliximab or vedolizumab. Dermatitis is another side effect directly from overstimulation of the immune system that more commonly occurs and occurs actually earlier than colitis. The median time to onset of dermatitis is about 4 to 6 weeks long, average being 3.6 specifically. But this is common, and up to 50% of patients receiving ipilimumab will experience some type of dermatitis, up to 30 to 40% with PD-1 inhibitors, such as nivolumab. NCCN categorizes the dermatitis based on presentation. You can see more benign presentation, like with maculopapular rash, and then escalating in intensity, something like bullous dermatitis. And similarly, the treatment is dictated by the grade of the dermatitis, and typically it's categorized by the percentage of body surface area that's covered by the rash. Grade 1 and grade 2 earlier stages, are typically recommended to start topical glucocorticoid creams at this point, and oral antipruritics if there's itching going on. For grade 2, you can start to consider the use of steroids at a slightly lower dose than recommended before, starting at 0.5 milligram per kilo per day. Grade 3 and 4, you're certainly holding treatment at this point, and also definitely implementing systemic steroids ranging from 0.5 to 2 milligram per kilo per day. There are many other inflammatory side effects to monitor, other itises. And this picture right here is a good representation of all that this may entail. Of course, not all of this is going to happen. Most of it is rare, thankfully. But pointing out some of the other notable ones, like pneumonitis, this is a serious side effect, somewhat rare, but more common in certain settings, such as in lung cancer. And nurses have a huge role in this by monitoring the patients, ensuring that their patients aren't having changes in respiratory function. And then if they are developing a serious toxicity and have been started on steroids, it is a long process for the patient in the steroid course and tapering the steroids. So nurses are involved in all steps of care and supportive care specifically. Other things like nephritis are even more rare, about 1% of patients. Thyroid function can certainly be impacted. Up to about 7% of patients in trials with the PD-1 inhibitors have had thyroid dysfunction. So in summary, there are many side effects to watch out for here. And nurses play, of course, an essential role. I'm going to stop here and go to a patient to summarize our immunotherapy section. So JN is a 50-year-old male admitted to the hospital with grade 3 colitis, likely caused by ipilimumab and nivolumab for metastatic melanoma. Past medical history is significant for type 2 diabetes. He is treated with supportive care measures and methylprednisolone IV 1 milligram per kilogram or 80 milligrams daily. After 2 days, his colitis has improved to grade 1 and the inpatient team is preparing for discharge. Which of the following steps should be taken next? So I want you to think about this, even though we didn't review this specifically, it's an important next step to know. So A, initiate slow prednisone taper over 4 to 6 weeks. B, initiate a rapid taper over 1 to 2 weeks. C, permanently discontinue the ipilimumab and nivolumab treatment. D, consider reinitiating treatment with nivolumab alone once the prednisone is at 10 milligrams or less. E is A and D, or F is B and C. And for time's sake, I will move on to the answer here, which is E, A and D. So you want to initiate a slow prednisone taper, and counseling the patient on the steroid taper is essential. Nurses will play a large role here, and it should be at least over 4 to 6 weeks. If a rapid taper is attempted, such as over 1 week, the side effect is likely to recur and perhaps even worse the next time. Discontinuation can be considered, certainly isn't necessarily wrong, but the guidelines in this circumstance would suggest consider starting treatment up again, but this time just with nivolumab monotherapy. And you can start treatment again once the steroid is at a low enough dose. So once you see patients at the 10 milligram or lower dose, we may be starting the immunotherapy treatment again. So to conclude, toxicities from anti-cancer treatment vary widely and may be predicted based on underlying mechanism of action of the drugs. Guideline updates do advocate for the use of olanzapine upfront in high emetic risk regimens. Treatment options for peripheral neuropathy and mucositis remain largely based on historical experience, and immunotherapy toxicities arise from overstimulation of the immune system and do have the potential to affect any organ system. Here are my references. Thank you so much, and I welcome any questions you may have.